Welcome everybody to this latest of the Royal Society of Medicine's webinars on the theme of COVID, and good morning, good afternoon or good evening to you, depending upon where you are in the world. Now, I know that all of us are in agreement that the COVID pandemic has been a global tragedy and one which very sadly shows no real signs of ending. But perhaps one positive thing has been the privilege that has been to hear well-informed and articulate people talking on our broadcast media and writing in our print media about something which they really do know about. We're very lucky today to have two more such experts. So over the course of the next 40 minutes, they're going to offer us their views on yet another aspect of COVID, which needs analysis if we're going to deal with this problem. We're going to be talking about the transmission of airborne diseases, and in particular, the way that ventilation can impact upon that. Of course, our focus is going to be on COVID-19, but I hope that what we talk about today is going to have wider implications. Now, our guests to discuss this topic are, first of all, Professor Catherine Noakes, who's Professor of Environmental Engineering for Buildings at the University of Leeds. Cath's research interests are in environmental fluid flow problems with a very strong focus on indoor air quality and investigating the transmission and control of airborne infection in healthcare environments. She's involved in experimental assessment of bioaerosol dispersion in indoor environments, modelling the spread of airborne pathogens and the effectiveness of control devices, and the development of epidemic models that can incorporate the influence of the physical environment and the behaviour of people. And Cath is a member of SAGE, and in the recent birthday honours, she received an OVE. Professor Gabriel is a distinguished public health physician and a former director of regional public health. And he's currently president of the section of epidemiology and public health of the Royal Society of Medicine, and a former director of the World Health Organization Collaborating Centre for Healthy Urban Environments. Gabriel's got a very distinguished record in leading inquiries into serious NHS clinical failures, and he's credited, I think, along with Sir Liam Donaldson, as defining a concept now very familiar to us, that of clinical governance. He's a member of independent SAGE. I'm John Moore-Gillon, and my perspective is that of a clinical respiratory physician. But my role today is really that of the humble backbencher who is here, like you, to the words of wisdom from my front bench colleagues, Professor Noakes and Professor Scally. We've already had a very large number of questions submitted in advance of this session and more coming in whilst we're live. Do forgive us if your own precise point isn't raised, but we're going to do the best we can to cover a broad range of issues which encompass the great majority of the questions that we've received or will be receiving. So perhaps I can kick off with you, Cath. Can you give us a couple of minutes setting the scene? What, from your perspective, are the challenges that we face?
Thank you very much, John, and for that kind introduction and inviting me to speak today. I guess I want to start off by saying that ventilation is a critically important control measure for this disease. We know now that the virus it can be in very small particles in the air, they can be transported across the room, they can build up if the ventilation is poor, and therefore people can become infected. We have to remember that ventilation is no magic bullet though. It only mitigates the airborne transmission beyond about 1.5 meters from a person. And we need to therefore make sure there are also other measures in place at the same time, thinking about like the Swiss cheese model that many of you will have come across. So making sure we've got things to manage close proximity and fomite transmission. So still making sure we've got masks, distancing, and surface cleaning and hand hygiene in there. Ventilation, I think, matters particularly when you're in an environment for a long duration and you're sharing that environment with other people. So that's a lot of workplaces, schools, healthcare, homes, some transport environments. And we do know from some of the evidence that ventilation or poor ventilation is associated with super spreading. So where one person can infect many people in quite a short duration of time. I also want to say ventilation is one of the hardest mitigations to apply well. Air is very complex. There's not a single simple rule. You can't just say wash your hands for 20 seconds with air. And even a rule like open a window has nuance to it. One day you might get good ventilation, the next day you might get different ventilation. And managing ventilation well requires both infrastructure and behaviour to come together. We can't see the air, it's invisible. It's very hard for us to just tell by looking whether that mitigation is in place. And so often we need other things to be able to help us understand that. But even though it's challenging, there are things we can do short term, and we also need to take that action now as individuals and organisations, both in the short term and in the long term. So we need to be looking to identify and mitigate the poorest ventilated spaces, first of all. And then we need to be thinking in the long term about the bigger challenge. We have a real legacy of poorly ventilated buildings, infrastructure that's been badly maintained over decades. We're not going to solve that overnight, but we do need to start a programme now to identify that, to address that ventilation, and address it at the same time as measures around energy, air quality, so we've got healthy environments that are also sustainable.
Kath, that's great. Thank you very much indeed. Gabriel, perhaps you can just tell us from the public health perspective what your take is on this and the topic we're dealing with today.
I think it's an absolutely vital subject. In fact, there's a piece in the newspaper today by Ian Dunt headlined, and I think he captures it quite well. Ignoring ventilation is the great unspoken error of our government's COVID-19 strategy. And I can see how we got to the situation where we ignored ventilation. If I look back at my own career in medicine and in public health in particular, when I was doing my postgraduate training in public health, we paid so little attention to infectious diseases. The thinking was that, well, the science, the pharmaceutical industry and other innovation was going to sort all that out, and we didn't have to worry really, and we could forget about all this old-fashioned public health stuff, the hygiene, the sanitary stuff that really brought us so far in the 19th and 20th century. We could ditch all that. Well, we have learned otherwise from HIV, from variant CJD, and now from COVID-19, and we should have learned, of course, from SARS a little bit earlier. And I think we've forgotten some of the lessons and need to relearn some of the lessons of history. And it is interesting if you look around the world and you see the places that have not lost the lessons of history, not lost the lessons from the Spanish flu, have done so well compared to us. And I think that ventilation is absolutely crucial for a number of reasons. It does require investment, but marginal compared to the huge amounts of money we've seen going into COVID-19. It does require effort, but it actually requires effort from all sorts of sectors of society and all sorts of groupings to change it. But for me, it is one, if it's been ignored, it should no longer be ignored. We need to move it up front in what we're doing and preparing for the future of a future that, rather than the future that I was brought up with professionally, a future where infectious disease continues to be an important part of life and death.
Yes, and I think what we're already getting from your responses has been that this is not just about COVID-19, is it? I mean, Kathy, you're looking to the future. Gabriel, you've looked back at the past and said we've not learned lessons, and Kathy, you're saying we're going to have to change in the future. Gabriel, I just wonder if I could just ask you about droplet transmission and aerosols, because we've got a number of questions on that issue, and I think that it is one aspect which, perhaps the general public may not have clear in their minds, even though many, if not most of us have.
Yes, it is a difficult one, and it's actually not a new debate really, because infectious disease people have been debating about droplet spread and aerosol spread for decades, about the relative importance of them. And over those decades, I think a lot of the emphasis has moved towards aerosol, towards airborne spread really. They both come through the air anyway, but that air is actually carrying virus particles and infecting people. So it has come forward, and it is a bit worrying, I think, that we're still, in the public consciousness at least, we're still back in the kind of sneezing into your elbow type place we were in, where we thought it was coughs and sneezes that was spreading diseases, to use the old phrase. And we have moved on from then, but not completely. I got my vaccinations in the last couple of months like everyone else, and I was amazed to find two things actually when I went for my vaccination. One was I was given an NHS leaflet about the vaccination, and there was a half a page in the leaflet all about droplet spread and nothing about air or ventilation at all. And then the second thing was, before I could sit down in a chair, it had to be thoroughly cleansed. And then after I'd sat in it, someone leapt in and cleansed it again. And this sort of hygiene theatre, I think, and the feeling that it was touch as well, that fomites, that touching objects was somehow important, has dominated the thinking. And the science doesn't really support those positions. And we really do need, this is a real opportunity for a good public health education campaign ongoing. And it's not being taken. I think there still is quite a bit of confusion in the public mind about this.
Yeah, Kath, what about monitoring of ventilation? We've got quite a lot of questions about CO2 monitors in schools. Should they be in schools? Should they be in public buildings and so on? Are they of value? And if you've got a high CO2 level, what should we be doing about it?
Yes, I mean, as I said earlier, ventilation it's very hard to see. So, I mean, you can do some very simple things like, just even look, where does the air come in and out of a building? You can even use little bits of smoke and things to work out where air moves, but it is very hard. And actually CO2 monitoring is one of the measures that is probably the most viable measure that allows us to assess what might be happening in environment. You have to remember that CO2 monitoring is not a direct measure of ventilation, it's a proxy. So what it does is it measures in our exhale breath, we breathe out CO2 and that can build up in the air. So the amount of CO2 in the air in a room, providing there's no other source like a gas stove, will tell you tells you how much of that air in that room was breathed out by other people. So it's actually a proxy for the number of people there and the ventilation rate. So as the ventilation rate increases, the CO2 level drops. As the number of people in the room increases, the CO2 level goes up. It also varies with people's activity. So when people are much more active, you get a higher CO2 level. It changes with age, with gender, so children breathe out less than adults do. So it's actually quite complex. You can use monitors in two different ways. So you can use them to check ventilation. You can put them in a space for a fairly short period of time and check that the ventilation's performing well, and move monitors between rooms and use that, particularly in mechanically ventilated buildings. You can also use them in naturally ventilated buildings where users manage the ventilation themselves, usually through the windows. And you can have a display and then people can respond to that value. It's hard to say exactly what values we should have, and we should bear in mind that any values that we do give are not hard numbers. It's the outdoor value can change, which means the indoor value can change. So, but typically if you've got CO2 below about 800 parts per million, you don't need to worry too much. Your building's probably quite well ventilated. If you've got CO2 that's routinely above about 1500 parts per million, then the chances are your building is poorly ventilated and you need to do something about it. And if it's between the two, I guess you're trying to move it towards that lower end, but I would be tempted to focus much more effort on the spaces which are really poorly ventilated, so are regularly sitting at those high levels, as opposed to mitigating the ones that maybe are sitting just over the lower level.
Before I come back to Gabriel, can I just ask you about air conditioning? I've got a number of questions about air conditioning. Is that bad? Is it blowing the stuff around?
So again, that's a difficult one. It depends, I think, is the answer. So sometimes air conditioning is combined with ventilation in a building. So it's part of the mechanical ventilation system of a building. In that case, it's probably okay because it's cooling the air and supplying fresh air at the same time. But many buildings have these recirculating units. We've all experienced them. Nobody can ever work out how you control them properly. Those are the worrying ones, because what they do is they mask the fact the ventilation's poor. They make you feel comfortable, but all they're doing is recirculating the same air over and over and over again. So if those ones are used in spaces where you've got good ventilation, they probably don't pose very much risk. But if you've not got any ventilation, then essentially they're hiding the fact that there's a problem.
Gabriel, can I ask you about, there's a question from David Friedman, about places like museums and galleries, going back to maximum capacity. From the public health perspective, are you happy about that? Or would you, in an ideal world, to reduce transmission, say no, they should be still restricting numbers?
I think it depends on the venue, as Kath said. It depends what's going on there, and it depends on the size of it and the air volume. That's and my feeling is lots and lots of places could be made safe, and certainly far safer, including those places. And it is very interesting what they choose to do and what they don't choose to do. And I personally think we should be having a sort of a proper assessment of public places, all public places and workplaces. It's interesting. I said earlier about how different places do it different way. If you're interested in schools as one of the places where a lot of people congregate and where many people work, in New York, they've a tremendous legacy from the pandemic, the Spanish flu pandemic. And if you're a parent of or a member of staff working in New York in a public school, you can go online and see the report, not just for your school, for the individual classroom, because every room in every school is numbered. And you can look up the ventilation report for the classroom that your child is in or that you may be teaching in. And it will tell you about all of the things that have been mentioned, about whether there is air conditioning, the state of it, what the filter is, what the state of it is, are there windows, can they be opened, all of that. And it'll show a list of the remedial actions that are needed. And I think we need that sort of information to be developed for all sorts of public spaces, including museums, galleries, and places of work.
Museums and galleries are one aspect, of course, of the general easing of restrictions. How comfortable are you about travel, public transport and so on? And perhaps everyone's going to be wondering about masks and whether we should be wearing them. So let's talk about masks for a second.
Yeah, they absolutely go together. And I think one of the things that represents a change, I think, in terms of our understanding, as we understand more about the air being the vehicle rather than droplets being the vehicle, is that we need to rethink our policy on masks. And the face coverings that were introduced at the beginning, because of course there weren't masks available to the public, they just weren't for sale to the public, and we needed all of the high quality protection we had for the NHS and other vulnerable locations. So we had this sort of dig for victory thing of people making their face coverings out of layers of cloth, and you still see people just pulling jumpers up over their faces or scarves over their faces and so on. And whilst that might have been partially effective in droplets, it really isn't suitable for dealing with what we know now about the increased problems of aerosol transmission, that air is really the appropriate thing. And I would be very inclined to go the way that very many countries in Europe have gone in terms of mandates for mask wearing on public transport, but mask wearing that is up to the standards, to the FFP2 or FFP3 standards or their other equivalents. So I think we should be, rather than abandoning mask wearing, we should be doing it better, and we should be doing it better with better masks, and we should be making those masks available free in places like schools. And I think employers should be making them free as well for people where the ventilation, working in places where the ventilation is not yet good enough.
Yeah, on a personal basis, I've gone online and bought myself a pack of FFP3s, and when I climb on the Victoria line of Brixton Station to go into town, I wear an FFP3. Kath, what do you feel about travel and masks?
Yeah, so I think travel is one of those situations where you are in closer proximity to people, and I think therefore the mask wearing becomes a more important part of the mitigation. Obviously ventilation is part of it too, but I think that it is one of those settings where mask wearing is important. And I think we also know that the benefit to an individual is going to be very much from the quality of the mask that you wear, but the benefit for the population is about having everybody wearing masks, or a large percentage wearing masks. And then you're also capturing those droplets of aerosols that carry the virus from the person who's infected. And actually we know that masks will block many of the different sizes of particles, so they'll actually also manage the droplets, they'll manage the fomites, and they'll manage what's in the air. So they're a very effective control. And it works as a population level control. It's very hard to demonstrate that how well they're effective, because with all of these things, they've all been introduced at different times. We've been changing restrictions all of the time. So it's very hard to see the effect of one intervention. But I do think they are an important one, particularly in times of very high prevalence of virus.
Let me put you on the spot, Gabriel. Were we wrong to back off, or was the government wrong to back off in terms of mask wearing in shops and so on, and leaving it up to the responsibility of the great common sense of the great British public?
Yeah, well, the common sense of the great British government would be much more valuable, I think, at the moment. we shouldn't have really moved away from mask wearing. And I do feel terribly sorry for people, particularly in retail situations or customer care situations where they're having to face person after person all day, and sometimes at far too close quarters, and sometimes people are disrespectful. So I absolutely think if I was in charge of a retail place or a place with close customer service, I would absolutely want my staff, and if I was working there, I would certainly want to. And just one caveat to the mask wearing, and there are selfish masks available. So you can get a FFP3 mask, and a lot of them that have valves, and they have exhaling valves. So the mask will be good at protecting you, but it will be no use whatsoever at protecting anyone else. And we simply shouldn't be tolerating those. We need to be properly masked with proper masks.
Thanks. Kathy, a lot of questions about aeroplanes. What about safety of travel on planes?
Yeah, so again, I mean, it's an environment where you are close to people, you're close to them for relatively long periods of time, usually. There is some evidence of spread on aeroplanes. Most of it came from early in the pandemic, before masking was introduced. Aeroplanes do have quite good ventilation systems. On the whole, they have quite a high, although they recirculate the air, they recirculate it through quite good filters, which means that the risk of airborne transmission throughout the whole of a plane becomes lower. But you are in close proximity. And I think we also need to bear in mind that it's not just the flight itself. It's as we queue through the gates, it's as we go through the airport, it's the public toilets in the airport, it's all of those other interactions that people can have. And it's the same with workplaces. It's very easy to say, oh, there are some cases associated with travel, therefore it must have happened on the plane, or there are cases associated with a particular workplace, therefore it must have happened in the office. Actually, transmission can happen just about anywhere where you put people together. So we have to think about all of those spaces where people interact together.
John, could I come in on that one about?
Of course. Because
it's very important. And I think the emergence of more transmissible variants, of course, changes the game as we go along. And we had one example of an amazing flight from Delhi to Hong Kong in April this year, or late March, early April of this year, where there was such a level of transmission on that aeroplane, with 49 cases identified almost immediately, and I think it got up into 60 just off one plane, which it was something like a third of the passengers tested positive. And the only reason we know that and have good evidence about that is because they had very good quarantine measures in Hong Kong. So we've got some really standout examples of that really do prove the transmission on aeroplanes. And I worry about more variants and that becoming even more difficult.
Kath, what about things like the Virobuster ventilation system? Do these work? Are they effective? Should we be introducing them?
So I'm not familiar with the Virobuster one itself.
Right.
I think there are a lot of these air cleaning technologies that are being proposed now. So I think there are some things which can be very beneficial. We know that HEPA filters, for example, they're high efficiency particulate filters, can be quite effective. There's some quite nice data from schools in the US now, which is starting to show that schools which had implemented these had lower rates of transmission. And there's good lab studies that show that they work. There's also ultraviolet UVC devices, which can also be effective. There are a number of other technologies out there, particularly things like ionizers, various other things, which some of them might be effective. It's very hard to say. Some of them are clearly not. There has been evidence that they're not. And some of these will may be effective as a biocide, but will also be effective at harming you. So you don't want something that's going to put ozone in the air and then is actually going to create a different respiratory harm from what you've put there. I think in terms of using these, again, there are no magic bullets, and quite a lot of people are looking for a technology solution, a magic thing that they can put in a place and that's your answer. And there is no magic bullet. So these devices, particularly like a HEPA device, will work best in places that are poorly ventilated. If a place is already very well ventilated, the benefits are likely to be much more marginal. So I would be, if you're looking to invest in these, placing them in places which really need that additional help is the first priority. And again, we need to remember that some of these devices, essentially what they are is like a box with fans in it and a filter in, and it pulls the air through that. If you've got a tiny device in a big room, it will have almost no effect. So you have to size the airflows, and you have to make sure that they've got sufficient air movement to move the air around the room to get the air through it. Otherwise, what you end up with is a very clean corner of a room and nothing else. So
I mean,
yeah.
Clearly technical fixes are not the answer by themselves. But what about behavioral, Gabriel, behavioral change? What would you, as a public health physician, how would you like to see us all behaving, and, you know, long-term changes in behavior?
Well,
are you hugging as many people? I've cut down my hugs enormously.
Unfortunately, I'm not. I do think, and because there is such a good evidence base for the health benefits of hugging, Cass quite right, there is no silver bullet here, and one of the failures, I think, of the government has been they've overindulged in the search for the silver bullet. We've had wild enthusiasm for several things. You know, antibody testing was one, apps was another, you know, lateral flow tests another, and all of these kind of things have their role, but what you need is a coordinated, integrated response, whether it be about the issue of classroom safety or all of the aspects of the entire pandemic. So there is no one response. Behavioral is really, really important. And I've been very privileged working on Independent Sage with some fantastic behavioral scientists, and I've learned so much from them. And they are so important to us. And one of the things that they say that I think is very important is that people need clear and consistent messages about behavior, and we haven't given them those during the course of the pandemic. You know, there are numerous instances of the don't go to work and then go to work because we need you to go into the city centres, and then within a very short period, no, don't go to work, and all of that sort of messaging and you know, and behavioral stuff like the eat out to whatever it was, you know, to that economic program designed to get people into close proximity across tables in restaurants, just at a time that we got the virus sort of semi under control. I feel sorry for people, but I think sometimes during the pandemic we've seen great common sense from the public when they have actually not followed what the politicians told them to do. And they thought, oh, well, that sounds a bit dodgy to me. I think I'll not really do that for a while. So I think coming out of this, we will have to think of a lot of the behavioral stuff, but it also made me think, John, if I may, about education as well, and that we don't teach people enough about health, about their bodies and about the environment, about the influences on their health and how to keep themselves healthy. And we certainly don't teach them to recognize early disease. And I think as part of the response, I'd love to see more education of us all about the behaviors that are right and wrong, and as well as about how our body works and how you can get infected.
Maybe starting in primary schools, starting very young. You know, your kids are taught how to clean their teeth and wash their hands, and we need to learn these things. Kath, can we just broaden this? Sorry.
I was going to say, can I come in here on behaviour and ventilation? So, you know, there are some buildings that are just very badly ventilated and people can do almost nothing about it. It requires new infrastructure and a change to that design. There are an awful lot of other buildings where, though, we can do some simple interventions through a combination of better guidance, better public understanding, user understanding, and some better maintenance. So as an example, there are a lot of buildings out there which have got windows that should open but don't. They've been poorly maintained, they've been painted shut. They're often high level windows which are often hard to reach, and people have taken away the cords and the poles that were once used to open those windows. But with some of that maintenance, relatively simple maintenance, we could reopen some of those again. And then if we think about how we can learn how to use windows, so there's a bit of a sort of perception that a window is all or nothing. It's either open or it's closed, and we must open it all year continuously. It's not necessarily true. So the amount of ventilation you get depends on the temperature and it depends on the size of the opening. So when it's very cold outside, you need a lot less opening to get good ventilation than in the summer, where you need your windows open wide. And particularly in the cold weather, if you have windows that are high level and you open those high level ones, what happens is the cold air comes in at the top of the room and it mixes with the warmer air in the room. And instead of giving a cold draft, it provides you with ventilation without over chilling you. Similarly, you don't have to necessarily have a window open all day, every day. You can open them intermittently, provide airing to rooms, particularly rooms that have been occupied for a time, air the room afterwards, allows us to balance temperature and ventilation better. But it's a combination of having the right infrastructure, which often is just a simple maintenance job to make sure they're right, with some good guidance and understanding about an education about how we use that infrastructure properly.
I'm going to come back in a minute to ask you about windows again, but Gabriel, I'm going to ask you about masks again, and particularly masks in the healthcare setting. Heidi Eagle has asked a question, as well as other people, about hospitals switching staff to wearing FFP3 masks. I don't think it's politically uncontentious that staff were not well protected last year. Are we protecting them enough at the moment? Should we be upping?
I don't know, actually, is the answer, and I'm not sure anyone knows. And this brings me to, having said, the answer is I don't know, Joe, but the point about it is we need to know more about this, and we need this to be documented. So we need to know about the ventilations in all of the places that we're working in, whether they be hospitals. And the hospital design has changed over the years, which is something we might come on to make it much more difficult to know whether a room you are in is well ventilated or not. We need to know all of this information about windows and do they work and so on. I was asked to go in and teach postgraduate students in a beautiful room with big high sash windows, a Victorian building, fantastic ventilation, or at least it would have had fantastic ventilation if the windows hadn't been painted shut for decades. Yeah. And all of that stuff. And I should have been able to, in my view, be able to look up online, see what the ventilation was like in that window. I should be able to know when I'm working in a hospital, what are the mandates about masks and how effective they are in my particular place or in my care home or wherever. And I do think there is a real role for trade unions in all of this, working with the health and safety executive, for example, about standards of ventilation in workplace, to make sure that the law is obeyed. And the law actually states that employers must make sure that there is an adequate supply of fresh air or ventilation in enclosed areas of a workplace. And it's very hard to know whether that law has been obeyed if we don't have any assessment of that.
I think that's the point, isn't it? Because most of us are aware that employers got to keep the temperature within certain limits for the staff to work there. I think many fewer people are aware of the regulations about fresh air and ventilation, but it is pretty easy to measure the temperature, and it's much more difficult, as Kath was telling us. Can I just come back to windows for a second, Kath, before broadening this out to matters like design of hospitals now and in the future? Should I be keeping the windows shut to save the planet and prevent global warming because I'm not using up as much, not heating my house so much, or should I be keeping them open, the cold air whistles in, and then I have my heater going to keep me warm when I'm contributing to global warming, burning all those fossil fuels?
Yeah, so this is where we need to find that balance. I mean, if we prioritize, for years we've prioritized energy in buildings. So I think, yeah, we need to balance things. For many years we've focused on too much on energy in buildings. But if you think about a building, what's the whole purpose of a building? The building's for the people inside of it. So if I want to say my building is performing well, it's not using any energy, fantastic. But if it's an appalling environment for people, it's a fail. So we have to balance it. We cannot just shut all the windows, seal up the buildings and say, look, we're saving energy, because if we save the planet but no humans are left on it, it's not much use, is it? So we actually have to find ways in which we can do both at the same time. So, actually the short term is we will have to open windows. The longer term is we need better ventilation system designs which allow us to manage the energy consumption and manage the health of people in buildings. And they exist. We already have technologies which can do it. And even in, naturally ventilated buildings, the right management with the right design and use of windows can enable you to balance those two things effectively.
Gabriel, a public health perspective and hospital design. I trained at St Thomas's, where a bit of the hospital was a whopping great long corridor with Florence Nightingale's pavilions sticking out of it. In fact, she helped design the place. And the other bit of the hospital was a big white cube where 90% of the volume of the building had no outside windows at all. What are your views on future hospital design? I'm going to come back after your response to Kath to ask for her opinions as well.
Yeah, I think hospital design is a very important issue, and I have noted a tremendous change in my career. I used to be, as a public health doctor and trainee, I was involved in hospital design, and I would be sitting on planning teams, and I remember the things that the trends, and the trends were moving away from natural ventilation, natural light, even removing washhand basins, because we thought, as I said earlier, bacterial problems or hygiene problems were a thing of the past. So we removed washhand basins in order to get more beds in. And we need to relearn some of the lessons about hospital design. There was a standard hospital design for England called the Nucleus system, which was building well into the 90s and maybe slightly beyond. And Nucleus was very good with a cruciform shape off a central corridor, naturally lit, naturally ventilated in many cases, and it was easy to seal off if you had an infectious problem in one of the wings. And we've lost that and replaced it with the boxes, which may be cheaper to build and undoubtedly cheaper to build, and no doubt the engineering is superb, but we also know that they're very difficult to modify, to cope with new things and to change in a way that the old buildings weren't. And the same goes for design elsewhere. One of the learning points for me was about my school in Belfast, and I grew up and went to a school in Belfast built by a wonderful English architect called R.S. Wilshire, he worked in Belfast on the Education Authority, and he built about 30 or 40 schools on sanitary principles with the very tall windows that Kath was talking about, with ropes to open them at the top and a metal retainer against which they came out against which they came out at the bottom, and plenty of sunlight, no internal corridors. There were open verandas around the place. And that was done to prevent airborne infectious diseases. That was the whole purpose of it. And we seem to have lost all that. And there used to be open air schools, and I live in Bristol now, and the last open air school in Bristol shut in the 1960s, but every local authority had open air schools for vulnerable pupils, and they were taught largely in the open air, very well-fed, nutritious food, and spent most of their time outside in all weathers, but wrapped and prepared for it. So we've lost the ability to cope, I think, with. I was on an interview. I was doing an interview on a radio program, and someone asked me about, but won't school children get frozen if we open the windows? And I said, well, I was never set out as a boy without a vest on in the winter. And that caused uproarious laughter, because apparently there are no such things as vests now. No one wears vests. And I have to talk about base layers or body armor or stuff like that. But we need to get a little bit, readjust our connection with heat and cold, and when we're prepared to experience it and when we're not.
Kath, looking to the future, what advice are you going to be giving government or commissioning bodies about the design of buildings? You've only got 4 hours to answer that rather simple question.
Yeah, so I think it is, first of all, we need to make sure that health is as important as all of the other factors. So we need a sustainable building, needs to also be a healthy building, and that has to be one of the major principles. I think the other important thing, though, is actually we do have technologies, we do have designs, we do have standards. They're probably not perfect. There are things that probably should change. But one of the real challenges is compliance. So even modern hospitals, there's been a couple of examples in the past few years, hospitals in Glasgow and Edinburgh, which are new hospitals built to the newest standards, but don't comply with those standards and can't demonstrate they comply with those standards. And actually that's about how we go through that design process properly, how we involve the right people in the design process, how we sign off on that design process. And I think there's a very big learning curve needed here and a very big change needed for the construction sector, because a lot of the failings come through somewhere in the middle of that design and construction process, because we shouldn't be in a position where a modern hospital cannot demonstrate that it meets current building standards.
Gabriel, do you think that there's going to be a long-term change in behaviour? Are we going to be not hugging so much, not shaking hands so much, keeping distance, or do you think that if this was over a year from now, we'd all be, back where we were?
Well, these behaviours change anyway, don't they? I mean, hugging was never big in England until relatively recently, I think. It's become much more fashionable.
Yeah.
Shaking hands was always the thing. And I think we will get back to a normal pattern of behaviour before too long. I do think we are likely to go the way of the Southeast Asian countries in terms of people being much more conscious about face masks and when it's appropriate to use them. And I quite like a culture that would say, well, if you have a cough and a sneeze, maybe you would be as well wearing a face mask for a few days to make sure you're not passing it on to everyone else. It's the old coughs and sneezes spread diseases stuff, or the things that used to be on the signs on the buses, no spitting and so on. We used to spit, and we managed to change that and forget about it because it was associated with the transmission of tuberculosis, as you will know well, John. And so we can change these behaviours and modify the behaviours. So I think there is room for some modification, I think, yes.
If I could put the two of you on the spot by asking, I'll go to Kath first of all, about saying what 2 or 3 things can most people do to reduce their risk and to help protect others? Gabriel's got the lucky bit because he's got 30 seconds to think about that. But what 2 or 3 things?
The 2 or 3 things they can do, first of all, is if you're sick, don't go out, stay home. Because, any suspicion that you're sick, don't spread that disease to anybody. I think the second thing is to be aware of your environments. So to, vote with your feet. Don't go in those spaces which are unsafe as much as you can. And I think being respectful, remember that we're not in this as individuals, we're in this together, and my behaviour impacts you. It's not about individual risk anymore. So wear your mask, keep your distance, follow the guidance, because it's about protecting each other, not about protecting just yourself.
And Gabriel, I'm going to put just a bit of spin on that. What about in healthcare settings? Because most of the people who are dialed in today are working in hospitals, working in general practices, working in other healthcare settings. Is there anything they can do to reduce the risk to themselves personally? I mean, should we be effectively mandating behaviour of the people who come and see us and visit us in our healthcare settings?
I think we should, and we have a real duty. We've had a couple of very tragic spreading incidents in the health service where multiple patients have died on the same ward, for example, on a hematology ward, and spread by the staff. And I think we have a duty, both as members of staff and also as patients, to try and prevent healthcare settings being a source for infection spread. And we've all got a responsibility, I think, whether you work in the health service or whether you work anywhere else. We should be asking more questions. We should be asking questions about the places in which we're expected to work as a healthcare provider, or we're expected to go as a healthcare consumer. And we should have a right to know what the ventilation is like. I mean, many of our primary care premises, for example, which are the places that there's most interaction between the healthcare system and healthcare professionals, are not necessarily purpose-built. They can still be in older buildings. They can still have basement offices and surgeries and so all that stuff. So all of us need to start asking questions about the quality of the spaces in which we're working. And that's a real role for trade unions and professional bodies to be giving guidance, and for the government to making sure the regulations are protecting us all and are revised to protect us all in the light of this pandemic.
Yes, and that brings me back actually to something you said very early on in this, which is that in New York, for instance, you know what's going on in your workplace. The information is there, or at least ought to be there, and we really haven't got that, have we?
No, we haven't. There's nothing quite like a clipboard and a pencil and going around and checking things. And if you have got an air conditioning system, and as Kath pointed out, some are useless because they're just chilling air, the same air but chilled, and some could be very good if they've got the right filters in place. And we need an educated public that knows what the questions to ask are, and educated trade union officials and educated employers, because most employers don't want illness amongst their employees. That's very bad for business. And employers should be encouraged and helped. And when you think of the amount of money that has been spent and has been wasted, for example, on the NHS test and trace system, which as Sage has told us is only of marginal efficiency, those billions would have helped enormously with improving the ventilation and protecting the safety of workers and members of the public right across the country. And we need that level of investment, I think.
Kath, one last question for you. Should trains with electric doors open the doors automatically at every station, as opposed to just opening the doors when someone presses the button?
Possibly so. I mean, I think, again, I'm going to say it depends, because many trains will have quite good mechanical ventilation systems.
Okay.
I mean, the tube is an interesting example. Everybody perceives the tube is really badly ventilated. Actually, the ventilation rates in the tube are really quite high. The reason being is because you've got so much heat in there, you've got to get rid of it. Now, the air quality is poor, but from a COVID perspective, there's actually quite a high ventilation flow rate in an underground train. And I was surprised to find that out as well, but it is true. So, I think it does depend. Obviously, opening the doors will make some difference, but in some cases, it might be a marginal difference. So we need data to tell us.
Thank you very much. Now, I'm going to wrap up now at the end of what I'm sure you'll all agree has been a stimulating and lively 40 minutes. Huge thanks to our two guests, Professor Gabriel Scanlon and Professor Kath Noakes, for the insights they've given us during this time. And I think as well as going away better informed, I think you'll agree we've gone away with food for thought. There's things for us to think about, which in the course of my everyday clinical life are not the sort of things which I normally consider. I think, Kath and Gabriel, if you listen very carefully, you can actually hear the rumble of applause from around the UK and indeed internationally. So very well done indeed. And many thanks as well to all of you for coming online and joining this Royal Society of Medicine session today. The next one is Thursday, the 29th of July, again at 12:30 British Summer Time, 11:30 Greenwich Mean Universal Standard Time, when this will be an in-conversation session with Professor Hugh Montgomery, a distinguished ITU specialist, who's going to give his perspective from the clinical point of view on the easing of restrictions. And it remains for me to wish you all a very good day, or indeed good night, and to stay safe and well. Goodbye.